What you can see over here is an illustration of the lower abdomen with the schematic of the small intestine and the large intestine drawn over it. You can also see the abdomen being divided into 4 distinct quadrants with the help of 2 distinct planes, a horizontal one more or less at the level of the belly button, the umbilicus, and a vertical one more or less in the midline. The small intestine is approximately 6 to 7 meter long and extends from the stomach in the left hypochondrium all the way down to the large intestine, mainly the cecum, in the right lower quadrant of the abdomen. The small intestine is comprised of 3 subparts: the duodenum, color-coded in red over here, the jejunum, which has been color-coded in blue over here, and the ileum, which has been color-coded in yellow here. The jejunum is the second part of the small intestine. And if we divide the small intestine into 5 different segments, all along its length, the jejunum constitutes the proximal 2/5 of the small intestine, distal to the duodenum. And you can probably appreciate here that it lies mainly in the left upper quadrant of the abdomen. The ileum is the third part of the small intestine and extends from the jejunum all the way down into the cecum. It lies mainly in the right lower quadrant of the abdomen and sometimes extending down even a little bit into the pelvis as well. Now this is an illustration of the front of the abdomen. In the left image, you can see that the anterior body wall has been removed so as to demonstrate the greater omentum, which has been shown in kind of yellow over here because of all of its fat deposition, and you can see the anterior abdominal organs as well. Note that the inferior edges of the right and the left lobes of the liver are visible as well here. We, however, are interested in the greater curvature of the stomach, and we can see which is kind of visible over here, and we can see the greater omentum draping down inferiorly from it. Note that the greater omentum has concealed most of the small intestine and the large intestine, and hence they're not clearly visible. So what you can see basically over here is the anterior surface of the greater omentum. Now, in the image on the right over here, we can see that the greater omentum has been reflected superiorly. So basically, it's just flipped over so as to expose the underlying transverse colon and the small intestine. So, I mean, the basic difference between the left image over here and the right image here is that here you're looking at the anterior surface of greater omentum, and since it's a double fold of peritoneum, you can see when we reflect it over, then the transverse colon is kind of pasted on its inferior surface. So here, although on the left you can see an impression of the transverse colon over here, but you can't really see it directly. But now we flip over the greater omentum, and we can see the transverse colon directly pasted on its posterior side over here. Now, in the right quadrant, and obviously you can see the small intestinal bowel, the small intestines over here. In the right lower quadrant, you can see the cecum and the ascending colon leading into the right colic flexure, and then continuing as the transverse colon. And you can also see the left colic flexure over here, which then transitions to become the descending colon on the left side. And we'll briefly talk about these different subparts of the intestine, of the large intestine, in the next slide. To study the abdominal viscera in situ, first make a midline incision in the diaphragm, then reflect the diaphragm superiorly. Remove the left lobe of the liver by giving an incision close to the falciform ligament. Identify the greater omentum and mobilize it. Note the transverse colon. Identify the stomach, the greater curvature of the stomach, and then the lesser curvature of the stomach. Identify the fundus, finally note the pyloric portion, palpate the thick wall of the pyloric sphincter, find the lesser omentum, both the hepatogastric ligament and hepatoduodenal ligaments. Put your finger inside the epiploic foramen and go inside the lesser sac. You can probe the omental bursa. You can probe the lesser sac with the help of your finger. Palpate your finger in the sac through the hepatogastric ligament. Re-identify the left lobe of the liver. Also identify the right lobe of the liver. Locate the gallbladder. Find the subphrenic recess. Now, with the falciform ligament reflected superiorly, identify the pyloric sphincter. Identify the first part of the duodenum. Note its relation to both the gallbladder and the first part of the transverse colon. Now reflect the greater omentum superiorly, flip it over, identify the jejunum, reflect the loops of the jejunum from its bed, and identify the duodenojejunal junction. Identify the suspensory ligament of Trias. Follow the jejunum in the upper left quadrant and then the ileum in the right lower quadrant of the abdomen. Locate the ileocecal junction. Trace the route of the mesentery of the small intestine from the ileocecal to the duodenojejunal junction. Identify the cecum. Underneath the cecum, look for the appendix. Next, look for the mesoappendix. Along with the vascular supply of the appendix, the appendicular artery. Identify the cecum continuing up as the ascending colon. Then look for the hepatic or the right colic flexure. Next, identify the transverse colon. Then look for the splenic or the left colic flexure. Then the descending colon, followed by the sigmoid colon, which will then continue down as the rectum and the anal canal. Find the paracolic sulci or the gutters on both sides of the ascending and the descending colon. Look for haustrations or pouches all along the length of the large intestine. Alright guys, so let's talk a little bit about what is a mesentery. Well, before we go on to discuss it, it is important for us to get our head around some of the basic concepts pertaining to the reflections of the visceral peritoneum. You know what, let's take some help from this cartoonic illustration over here, which represents a midline sagittal section of the abdominal pelvic cavity, which can be seen over here. Now, this being the anterior side, and this being the posterior aspect of the abdominal pelvic cavity. We can also see the vertebral column at the back over here, which kind of helps us orientate this slide over here. So now we probably all know by now that the abdominal pelvic cavity is all lined up on its inner side, on its inner wall, by a layer of peritoneum which is known as the parietal peritoneum. The same peritoneum then reflects as a double fold of peritoneum from the body wall and envelops different viscera, such as the liver, shown here, the stomach, shown over here, and the loops of intestines, this being a loop of large intestine and this being the small intestine over here. This double fold of visceral peritoneum is then given different fancy names in different locations, such as the falciform, coronary, or the triangular ligaments, as the parietal peritoneum jumps onto the surface of the liver as visceral peritoneum, or it could be called as the lesser omentum, as the double fold of visceral peritoneum jumps from the liver onto the lesser curvature of the stomach, or it could be called as the greater omentum, as the double fold of peritoneum hangs down from the greater curvature of the stomach. The same double fold of visceral peritoneum, as it reflects from the posterior body wall, which is shown over here. So as it reflects from the posterior body wall and envelops the small intestine, mainly the jejunum and the ileum, it is referred to as the mesentery. The mesentery thus interconnects the intraperitoneal organ, such as the intestine, with the posterior body wall over here. So you can see the posterior body wall over here would be covered over by parietal peritoneum. A fold is going to go over here from the top, another fold from the bottom over here, forming a double fold of visceral peritoneum, which then goes on and envelop the small intestine here. This therefore being the mesentery of the small intestine. Similar reflections of visceral peritoneum extending from the posterior body wall, once again from the posterior body wall here, and enveloping the large intestine, for instance over here, would be then referred to as the mesenteries of the large intestine. However, these are then given specific names, such as if you look over here in this mid-sagittal section, this is actually a cut section of the transverse colon. So this double fold of visceral peritoneum, this mesentery of the transverse colon, is known as the transverse mesocolon. Similarly, we have a sigmoid mesocolon, which would be the mesentery of the sigmoid colon. We have mesoappendix, which is the mesentery of the appendix, and so on. To sum up, all the mesocolons are in fact mesenteries of various parts of the large intestine. However, generally speaking, I mean, they are basically the mesenteries, but generally speaking, when we use the word mesentery, we are kind of referring to the mesentery of the small intestine, mainly the jejunum and the ileum. It is also important to note over here that most of the duodenum, except for its real proximal and distal ends, the most of the duodenum is an retroperitoneal structure, and therefore it doesn't have a mesentery attached to it. Right, so now that we know about the visceral peritoneal reflections, let's understand the relationship between the greater omentum and the transverse colon and transverse mesocolon. So if you look at this mid-sagittal section of the abdominal cavity, abdominopelvic cavity one more time, we can see the cut section of the stomach over here. This is the greater curvature of the stomach. So you can see the greater omentum hanging down from its greater curvature. It goes all the way down over here, and then it kind of takes a 180-degree turn at this point, and then ascends up, eventually merging with the posterior body wall. So if it's a double fold of peritoneum, the greater omentum, a fold of it is going to go up to the body wall here, a fold is going to reflect to the body wall over here, becoming now once again the parietal peritoneum. Here we can see the transverse colon, cut section of the transverse colon here, connected to the posterior body wall with its transverse mesocolon, which is again a double fold of peritoneum. Now, with time, what happens is that the transverse mesocolon and the transverse colon, they get pasted onto the posterior surface of the greater omentum, and thus obliterating any space which initially existed between the greater omentum and the transverse mesocolon. So we cannot see the posterior surface of the greater omentum at the back over here. What we can see is just the transverse mesocolon, which is kind of hiding the greater omentum underneath it, if that makes sense. This can be actually understood much better by looking at the abdomen from the front in this illustration over here on the right. Right, so what we can see over here is that that the greater omentum has been reflected superiorly, so we can still see the posterior surface of the greater omentum over here. Now, since it is reflected superiorly, we can see the transverse colon and the transverse mesocolon, which are now attached onto the posterior surface of the greater omentum. So we've got transverse mesocolon, we've got transverse colon, and then we can see the posterior remaining bit of the greater omentum over here. Okay. Apart from this, well, what you can see over here in this illustration is that the jejunum and the ileal loops, they have been retracted to the right. This is the right side here, and when they are retracted to the right, you can actually see the fourth ascending part of the duodenum over here curving anteriorly to join with the jejunum, so this being the duodeno-jejunal junction. And you can probably appreciate here that much of the duodenum is a retroperitoneal structure, and that's why it was behind the parietal peritoneum. Now it's kind of coming out through this little hole over here called the paraduodenal fossa, and then it becomes intraperitoneal and continuing as the jejunum. And when the jejunum and ileum, they become intraperitoneal, they would be having their mesentery attached to them, which you can see over here very nicely. Right, so guys, now how about if we actually jump over to another illustration, and on the right over here, and here we can see that the small bowel has been removed, right? And the transverse colon is once again elevated here to reveal its mesentery, the transverse mesocolon. The small bowel cannot be seen over here because it has been cut. The mesentery of the sigmoid mesocolon is also visible over here. So you can see a double fold of visceral peritoneum extending from the posterior body wall, this time enveloping the sigmoid colon, so this being the sigmoid mesocolon. Since the ascending colon and the descending colon, these are retroperitoneal structures, so they're going to be hiding behind the parietal peritoneum, and hence they don't have any mesenteries in the adults. Note the cut ends of the jejunum over here and the ileum over here, revealing the root of the mesentery proper. So this being the root of the mesentery, where the visceral peritoneum joins the parietal peritoneum, lining the posterior body wall. The attachment of the root of the mesentery to the posterior body wall is only 15 centimeter long, running downwards and to the right from the left side of the second lumbar vertebrae, running downwards and to the right, reaching on to the front of the sacroiliac joints, or in other words, simply from the duodenojejunal junction to the ileocecal junction on the right. On the contrary, the free edge of the mesentery is fairly long. It's approximately 6 meters in length and contains the jejunum and ileum in its tortuous free edge. Obviously, we can't see that over here. We can only see the root of the mesentery. So as the root of the mesentery is very short relative to its free edge, which is fairly long, the mesentery is consequently a fan-shaped structure. Lastly, before we finish, it might be worth knowing the important functions of the mesentery. They contain nerves, vessels, and lymphatics, and they convey these vessels, nerves, and lymphatics to the organs which travel from the body wall, passing through the double fold of visceral peritoneum or the mesentery, and eventually reach the organs which are being enveloped by the mesentery. The mesentery also permits the movements of the organs to which it is attached. All right, so the blood supply of the intestine can be better understood with some knowledge of the embryology of the gut. Have a look at this cartoonic illustration over here. This is the anterior side over here, and this is the posterior side. Anteriorly, this blue bar represents the gut. And think of the gastrointestinal tract as one long continuous tube. During development, the gut gets subdivided into three segments: the foregut, the midgut, and the hindgut. Posteriorly, we can see a schematic of the aorta over here, which can be seen passing through the aortic hiatus in the diaphragm at the level of 12 thoracic vertebrae. And then as it descends down in the abdomen, it gives off three ventral branches. Each branch is then destined to supply a specific segment of the gut tube: the foregut, the midgut, and the hindgut, along with the lymphatic drainage which follows the blood supply. The first ventral branch of the descending aorta is the celiac trunk, which supplies the foregut. The foregut then gives rise to the abdominal esophagus, stomach, and the proximal half of the descending part of the duodenum and other associated organs such as the liver, gallbladder, spleen, pancreas, and so on. The second ventral branch of the descending aorta is the superior mesenteric artery, which supplies the midgut and is given off somewhere at the level of the first lumbar vertebrae. The midgut then gives rise to the distal half of the descending part of the duodenum, jejunum, ileum, cecum, appendix, ascending colon, and the proximal 2/3 of the transverse colon. Just to note, the junction of the proximal 2/3 and the distal 1/3 of the transverse colon, that marks the junction of the midgut and the hindgut. The third ventral branch is the inferior mesenteric artery, which is given off from the descending aorta roughly at the third lumbar vertebrae, and that then supplies the hindgut. The hindgut gives rise to the distal 1/3 of the transverse colon, descending colon, sigmoid colon, rectum, and the upper half of the anal canal up to the pectinate line. Right, so this illustration over here highlights the course and targets of the superior mesenteric artery, which arises from the abdominal aorta about 1 centimeter inferior to the celiac trunk. So you can see that very nicely over here in this illustration. This is actually the hiatus of the abdominal aorta, which is inside the diaphragm. So you can see actually one of the crus of the diaphragm very clearly visible over here. This hiatus is situated at the level of 12th thoracic vertebrae, and we can see the descending abdominal aorta popping out from it. Now, this descending aorta is going to give off different ventral branches. The first branch is this one over here called the celiac trunk, and then about a centimeter below it, the second ventral branch is the superior mesenteric artery, popping out from the abdominal aorta roughly at the first lumbar vertebral level. Now, the first branch which is given off from the superior mesenteric artery is the pancreatico-duodenal artery. And we can see that very nicely over here, and you can see that it kind of is in a situation, is in a position to supply blood to the head of the pancreas over here and to the duodenum, the pancreatico-duodenal, that anastomosis with the pancreatico-duodenal branch coming off from the celiac plexus, from the celiac trunk as well. Then after that, what happens is that the superior mesenteric artery runs down within the mesentery proper of the small intestine. So you can see that mesentery of the small intestine over here. These are the loops of the jejunum, and then these are the ileal loops. You can see the ileum going through the ileocecal junction into the cecum. Now, the jejunum over here gives off about 15 to 20 jejunal and ileal branches, which you can see over here, all in the mesentery of the small intestine. These intestinal arteries, they anastomose to form a series of arcades, and you can see those arcades or arterial circles all along over here within the mesentery of the small intestine. These arcades then branch off to give some straight branches which supply the small intestine directly. These straight branches are known as the vasa recta, which obviously directly supply the jejunum and the ileum over here. Now, as we transition from the jejunum towards the ileum, we can see clearly over here that the number of the arcades, they keep on increasing. So there are more arcades close to the ileum, and consequently, the length of the vasa recta is much longer in the jejunal area. And since the number of arcades increase, so the length of the vasa recta becomes smaller as well. So while doing dissection of the mesentery, this feature can be used as an important differentiating feature to distinguish between the jejunum and the ileum. So after that, the next branch of the superior mesenteric artery is the ileocolic artery, and you can see that over here popping off from the stem of the superior mesenteric artery. This ileocolic artery supplies the terminal ileum close to the ileocecal junction, the cecum, and the beginning of the ascending colon. It also gives rise to a branch which is called the appendicular artery, which kind of is visible over here. You can see the appendicular artery goes behind the terminal ileum and then enters into this mesentery of the appendix. This mesentery of appendix is called mesoappendix. The appendicular artery then runs in this free border, in this edge of the mesoappendix, to eventually be able to reach the appendix. Now, this appendicular artery is an end artery, which means that it does not anastomose with any other artery. Appendicitis, that may cause the obstruction of the flow through the artery, resulting in an infarction or tissue death of the appendix, subsequently leading to gangrenous appendicitis, which could potentially be life-threatening. So after the ileocolic artery, the superior mesenteric artery also supplies the ascending colon and the cecum as well through the right colic branch. And I mean, there could be a potential overlap in the area of distribution of the ileocolic in the lower colon and the right colic, but for sure the ascending colon gets supplied by the right colic artery. The middle colic artery is then the last branch of the superior mesenteric artery, which enters the transverse colon through the transverse mesocolon to supply the proximal 2/3 of the transverse colon. So now the veins usually correspond to the arteries. So you can see the inferior mesenteric in this illustration. You can see the inferior mesenteric vein over here, and this being the superior mesenteric veins. You can see all the corresponding venous branches of the superior mesenteric vein over here. You can see the jejunal ileal branches here, the similar arcades and vasa recta being formed over here. You can see the ileocolic, right colic, and then the middle colic branches. In the inferior mesenteric vein, you can see that is draining mainly the hindgut, and these would be the left colic branches, the sigmoidal branches here, and then the superior rectal branch here. Now, the venous drainage is a little bit different as far as the final drainage point of this venous blood is concerned. So what we can see over here that the inferior mesenteric vein and superior mesenteric vein, they don't drain directly into the IVC, into inferior vena cava. Instead, what happens is that the inferior mesenteric vein drains into the splenic vein. You can see the splenic vein coming over here from the hilum of the spleen, and then once it has received the inferior mesenteric venous blood, it then combines, the splenic vein then combines with the superior mesenteric vein to form what is known as the portal vein. The portal vein then drains into the liver, and from the liver, hepatic veins are given off, and these then eventually pour the venous blood into the IVC, the inferior vena cava.